Any views or opinions expressed in this podcast are strictly the views or opinions of the presenter. Nothing in here is the view of the firms, corporations, financial entities that anybody represents. Nothing expressed here is a view of any regulator or semi-regulatory agency. All content is intended to be educational. Nothing in this episode construes specific investment advice, and if you do require advice, you should seek an appropriate advisor, be that a financial planner or a tax advisor or possibly a lawyer. And welcome back to the CE Drive podcast. This is Jason Watt. In this episode, which runs a little over time, I apologize. You're going to have about an hour and 10 minutes in total of content here. And I have COVID right now, so I have this cough. I apologize. I'll try to keep it out, but it's anyways. So we have for credits here, life insurance credits in all jurisdictions except Alberta. This would be good for an accident and sickness credit, not a life insurance credit. This is group benefits relevant content, so enjoy. It'll be financial planning content from FP Canada, professional development content from IROC, and insurance content from the MFDA side. It'll be approved for an advocacy credit as well. And the object is a Christmas present from my wife. I love these gifts that my wife gets me, like a leather-bound notebook here. She likes to buy me these nice notebooks every year. So a notebook is the object today. And let's roll into the interview because it's very long. All right, I'm joined here today. I've got a couple Davids on the call. We got Dave Patriarche, of course. This will be another episode of the CGIB Navigator podcast. And then David Stevenson, whom I've just had the pleasure of meeting. David, I know you're a sort of small town dentist at Carleton Place in Ontario, right?
Yes.
And can you give us a little intro about who you are, some background?
Yeah, I graduated in 1986, so I've been a dentist a long time. I went through the military, so I did work overseas as a dental officer in the Canadian Forces Dental Services. But then in returning to Canada, my wife and I are both dentists, and we have practiced in the little town of Carleton Place since 1990. I still continue to practice, although I've slowed down a little bit. I've gone from an owner to being an associate, but I've also been very heavily involved in organized dentistry since 1994. And that includes anywhere ranging from, I'm a recent past president of the Ontario Dental Association. I've also been chair of their economics advisory committee, which is the Ontario Dental Association's committee responsible for oversight of the fee guide. So that may be of value to this podcast. And I've also been the recent chair of the Pandemic Recovery Working Group, which is fairly much responsible for providing solutions and workable problem solving during the pandemic. And so hopefully I bring some value to the podcast. So fire away with whatever questions you can.
You will for sure.
I'll leave you with the hard questions here then.
I guess maybe just you can start out, and I apologize, I've got a bit of a cold, so this is going to be less of me and more of Jason today. But can you help people understand the difference between the ODA and the college and kind of the roles of both parts? Because quite often I hear people treat the ODA like a regulatory body, and it's not. But maybe you can tell a little bit about that.
Yeah, and Dave, that's an excellent question. And believe it or not, a lot of dentists have difficulty with that issue as well. And Jason, the province that you're in Alberta, it's only recently that they've separated. They've used to be one in the same body. So, there are overlaps. There's some shared perspectives with our respective mandates between the Ontario Dental Association and the Royal College of Dental Surgeons of Ontario, but they're very different in many ways. Some of the similarities are, they both are advocates for professional leadership, quality of care, building trust in our profession. We both do that. Where the main differences is the college's mandate is to protect the public. And the Ontario Dental Association's mandate is to advocate for their members. So that's one of the main differences and main perspectives. Another big difference is the college is not voluntary. You have to be a member of the college. You have to be a registrant. So that's what you get your license to practice dentistry. Whereas the Ontario Dental Association is voluntary. Now, we represent about over 90% of our members, which is a very good voluntary rate, but nonetheless, it is voluntary. But I think to generalize, the college, they establish the rules and enforce the rules. Whereas the association, we are consulted on many different levels, but our main role is to help our dentists, help our members and all the dentists of Ontario as well comply with the rules, help them meet the expectations that the college sets out. So, there are some overlapping of mandates, but there's a very distinct difference. The ODA doesn't make the rules. We help meet those expectations. Does that make sense?
Yeah, that's fantastic. In our industry, we would say, we have FSRA, the Financial Services Authority of Ontario, which basically does our licensing. And then we have associations like whatever CGIB, advocates, and everything that you can belong to voluntarily. Our participation numbers are probably closer to 5 or 10%, not 90. So you guys are way, way ahead. And on the insurers side, insurers are regulated by FSRA, but they have CLIA, CLHIA, that is their association and advocacy group. And again, in our industry like yours, advisors kind of think that CLIA is a regulator, and they're not. They're just, for lack of a better term, a union for the insurers to speak their voice and things like that. So I think that's great. Jason, you want to take the next one? Jason would take the next one if he wasn't muted.
If he wasn't muted, there we go. Sorry. So I actually have a follow-up with this one a little bit here, David. You were good enough to mention Alberta. Can you give, I don't know if you know off the top of your head, but is this common in most jurisdictions now where you've got that break between like an ODA and RCDSO, like the college equivalent, or is it still like, are Alberta and Ontario unique in this regard?
No, it's moving towards that. If you were to ask me that question about 5 years ago, I could list you that the relationship in Alberta was the Alberta Dental Association College. Saskatchewan is one unit, Manitoba is one unit, New Brunswick. Like there's various that have all been one association, but that view is changing. Ontario changed thanks to Bill Davis back in the 70s. I'm embarrassed that I actually know that because that will tell everybody how old I am. But in Ontario, it's been that way for a long time. But the other provinces are going that way, and that's that's a big driver of change across the province. But I think it's inevitable. There's some provinces that have given the associations time in which to do it. There's other provinces such as BC about 3 years ago just put the hammer down and said, no, you guys are separate and you have to go your separate ways. So it has been different, but the trend is trending towards a separate body to protect the public and to advocate for the association. And it's not like a union. It's not like a union. Sometimes we get compared to that, and there are some similarities, but we don't have a common negotiating agreement. It is really an advocate and services for our members.
Then I'm not aware of this at all, but I assume this is something Dave would know about. But David, the question here about the college's fees increasing. So I assume you're paying fees to both the college and the ODA, and I'm sure everybody's very sensitive to these fees when they change. So I don't need comments here, David.
Yeah, the college is an easy target, and I think it is across the country with that. The fees to the college increased by about $485 this current year. I'm not a member of the college executive council. I'm not a member of the college's council. So, but I, as a practicing dentist, I do have faith in their governance, that they do know what they're doing and why they're doing it. If, to give you the typical answer, that there is, they've had to do this. There's increasing funding for the professional liability because we get our liability insurance through our college. They are going through some governance changes that's being brought down from the province onto them as far as governance is concerned, and regulatory requirements that are increasing. They are subject to inflation just as well as I as an individual practicing dentist are. So yeah, it's easy to complain about, as they say, because they're always an easy target. But I do have faith that they have a proper oversight process in order to justify their increases. So
it's money well spent.
Those are my thoughts about it.
Yeah.
I did not know that they were. Is this similar to the physician model, the providing of your liability insurance? Is it?
Yeah, in Ontario they do. Yeah, we can get extra outside of the college, but they do provide it, the basics. And so that's the way just of ensuring that everybody has it. It's a condition upon registration.
Okay. Yeah, I only recently became aware of this for physicians, that it's essentially it's a pooled, like you don't go shop for insurance or whatever as a physician.
Yeah. So, and we're the same as advisors. We tend to buy it through our associations, but you can buy it on the street as well. It's just the power of the group tends to be pretty good for the most part.
Yeah, and I think it relates to your risks of what you're doing too. Different practitioners, in the medical world, obstetricians have a much higher insurance rate than the GP. In the dental world, oral and maxillofacial surgeons have a much higher insurance rate than so it relates to risks.
Makes sense. All right. Sorry, that's such a long digression there. So now we've seen so much change in the dental space. Can you talk about some of the drivers of that change? And maybe we can focus on Ontario a little bit here, David, since that's where your expertise lies.
Yeah, the typical changes, I always like to think that the typical changes and drivers of change in my profession of dentistry, they can be demand driven by the patient. They can be industry driven by technology advances. Those changes should be well researched, well evidenced, and by not just the source of evidence, but the type of evidence and the weight of evidence. Are they effective? Are they safer? Are they more efficient? Those are all things that we usually like to think are the typical drivers of change. And those still exist. They still exist. And but what's changed in change over the last few years. And I'm going to go back I'm going to say about 5 to 6 years ago where this started. There is some legislative compliance that's responsible for change. In other words, meeting our professional responsibilities. And that has so very much been driven by COVID over the last 3 years, where the protocols, where we haven't been able to rely on the evidence, we haven't been able to rely on the time to properly evaluate and weigh the evidence. We've had to make those changes really quickly, all in the interest of public safety. And with a little bit of uncertainty, we've had to make those changes utilizing what I call the precautionary principle. In other words, okay, we've got to be overkill in the safe department. We've really got to be overkill in the safe department. And, that's how it's been in Ontario. And believe it or not, I'd like to explain a little bit of the relationship that Ontario has with the other provinces, because that sort of situation is existing across the provinces, across the country, and it's also existing internationally. The Ontario Dental Association is a member of the Canadian Dental Association. So each of the different provinces and territories, with the exception of Quebec, although the relationship between Quebec and the Canadian Dental Association is very good, but each province and territory is a corporate member of the Canadian Dental Association. So the provinces in that relationship, we share a lot of services, we share a lot of the advocacy efforts, we share a lot of the information and research. So Ontario is not necessarily, speaking from Ontario, we're not like an island or a microcosm. if we are an island, we're the biggest friggin' island in the country. So there's a lot of influence there, both good and bad. So that sort of scenario, you asked the question, Jason, as it relates to the other provinces. Those other provinces, there will be subtle changes in the legislation compliance because healthcare is a provincial responsibility. But as general, we're all facing the same issues. And I would say that over the past 5 years, that legislation compliance, infection prevention and control has been a major driver. There have been some others, though.
I was going to say that was a big one in Ontario.
Yeah,
as far as affecting costs, and a big change for dentists that I don't think a lot of people really picked up on unless they were kind of hanging with dentists who were at the time pulling their hair out.
Yeah, exactly. But I'm going to toot my profession's horn here. At the beginning of the pandemic, everybody was thinking about how much risk dentists are. I mean, we're an aerosol generating profession. We got to take our mask, like the patient has to take their mask off. We're working in the mouth. We're spraying everything all over the place. That didn't pan out. Like, dental offices were not a source of infection.
Well, and you guys have a track history that is very, very good. And I remember years ago, we had a family member dealing with HIV/AIDS who passed away many years ago. And I said, what's this concern? And they go, we've been dealing with this forever, whether it's hepatitis C, whether it's HIV, now this. You've had lots of training in this and work in this environment on a daily basis almost. Yeah. So the pandemic was, a little bit more, but you're already there. You were operating safely, effectively, and so on.
Yeah, our starting point was a really great place to start from. Have we had to make some changes? Absolutely. But I do think our starting point was a really great place to start from. I can't just stress infection control and legislation, though. There are other changes that are coming into place, and they're almost a separate discussion on their own, but I can mention them a bit here. The business model changes, corporate dentistry, that is a driver of change as well. But oh man, I could talk about that forever. There's some of the changes that I think are worth talking about are teledentistry. Telemedicine has really played a major role in the pandemic. And, not just it's improving access to care of medicine and improving utilization of our medical services. That's very limited in the dental world.
But, yeah.
Very limited in the dental world.
There was a lot of jokes going on about the attachments to your iPhone to do your own dentistry. I mean,
yeah. For screening, and certainly it's been very helpful in our northern communities for triage and things like that. But the favorable movement forward and progress that you see in the medical world for telemedicine, you don't expect the same degree in teledentistry. I need my hands in your mouth. So
yeah,
I need my hands in your mouth.
Yeah, but it must come in handy if somebody after having a treatment says, okay, I've got this pain and everything, and you can maybe take a quick look and go, yeah, you might want to come back in, we'll get you some antibiotics, or exactly. give it a day, take a Tylenol, and
I honestly, I'm not saying it's not helpful. It's just not to the same degree.
Sure.
I did this. I actually had this because I have orthodontia in right now, and I had a question about them. And instead of having to go into the office, I said my orthodontist FaceTimed me and took a look, and he's like, "Yeah, no worries, it's all good. You can just wait till your next regular appointment." So yeah, that was pretty neat, actually. So,
very cool.
Yeah. Now, you mentioned sort of international pressures here. I find this interesting, David. This is one that, and by the way, there's going to be a bunch of financial planners listening who are going to harass me about not asking you about corporate changes, but we'll deal with that separately.
Yeah. Okay. So, no, I have no troubles talking about it. I don't know how long we have. We got 24 hours for this podcast. Is that what it usually is?
Give or take. Yeah.
Well, how about we defer that question? Maybe I'll hit you up separately for that. But but I am curious about the international pressures here, because, and I think Dave can attest to this in the group benefits world, where there's sort of like, we can often look at what's happening in the United States or in Australia or the UK as a little bit of a precursor to change that we might see in Canada in our space. And is that kind of how it works with dentistry too, David? Is that your sense here?
Yeah, there's the international level is a very interesting level to look at. And you have to look at the drivers of change in the international level, not just on the regulatory side of things. England and Australia have gone to a super regulator. Right now in Ontario, we have 26 regulated health professions, and each of those regulated health professions has a member of their own profession, if not as registrar, but as the president or a representative on their regulatory body. It's not quite the same as self-regulation. I think that's a dinosaur and it's gone the way, but it's certainly self-representation in regulation. But you've got other countries that have gone, no, we're just going to have a super regulator for all the health professions, and one can see the efficiency in that. There's pros and cons to that, but nonetheless, what are the pros and cons? It's happening. So that's a driver. The corporate model is a driver of international that we see, particularly coming from the States, the percentage of dental practices that are corporate owned. So that's a driver of change that we can look at the international model. The direct to consumer perspective of services like Smile Direct, orthodontic services, direct to consumer. These are things that they're not quite so prevalent in Canada yet, but we saw them coming from outside. And it even goes to relate to, hopefully someone will ask me a question later on about the National Dental Care Program. When we look at what happened with no chuckles, but when we look at what happens in other countries, you can't just say, Swedish model works, British model works, we got to take that. Every country is different, just like every province is different. You need to pick and choose. You need to see what doesn't work and what works. Would I want a system like the national health system in Great Britain? No way. Germany has a different system. France
wait a minute. Are you suggesting that people in Great Britain don't have the best teeth in the world?
I'm not going to suggest that. I'm just going to say
I'm sorry, I couldn't resist.
Their access to that care is very compromised. So we need to pick and choose, but it's coming. Like that model of a publicly delivered dental care system is coming. We know it's coming. We can make, I think, I'm very optimistic about that. We can make it work if we just target it, because we can't throw out what's been worked in this country. I better let some other questions go on, but but you need to pick and choose what other countries are doing. And there's some really good examples that we have to pick and choose from.
Fantastic. Should we move on to one of those other topics? I mean, we've got so many ways we can go.
Yeah.
I'm going to skip through some of the pandemic stuff and maybe come to the costs, and then maybe we'll come back to corporate dentistry if that's okay.
Okay.
And maybe you can tell a little bit about the ODA fee guide, the Ontario Dental Association fee guide, how it works, how other provinces are similar. And I mean, the timing couldn't be better because as of January 1, we have the new 2023 fee guide out, and it's a little bit higher than it has been in the past.
The highest that I've ever seen it.
Yeah, and in 25 years, I think we used to average about 2 or 2.5% a year increases, so kind of inflationary-ish, and then we all of a sudden hit the infection prevention legislation regulation, and that gave us a big bump, and then we mellowed out, and then all of a sudden, we're back up through the pandemic, and then post-pandemic, I guess.
Yep.
And now we're up this year to 8.5%, I think it is.
Post 8.5. Yep.
Yeah.
And that's the largest that I've ever seen. Having said that, even though I'm an associate right now, I'm very closely involved with the individual who bought our practice. So, I can see the costs. It's impossible to talk about that without talking about the pandemic, because it is directly related, and all I can I'd like to say that the pandemic has not created, but it has put in place certain expectations that will become the new normal. It has exacerbated certain conditions that were already there. So when you heard me talk earlier about the precautionary principle about being safer than you need to be. That's not going to change. That's what patients expect,
and nor should it.
Exactly.
Right? Yeah.
You know, I've done over the past couple of years so many television and media interviews, and the patients know what to expect now. They know when they look and they see an air filtration unit in the corner of the operatory. They know when they see that. I'm wearing a gown. I wear a bonnet now. I never used to. I used to wear a shirt and tie. So when I first started practicing. So they see this and they expect those changes. Things that have been exacerbated for the costs that have increased. The dental industry is no different from any other industry with regards to the manpower situation. And we have seen a real shortage and a demand for auxiliaries and helping us provide the services that we provide. And there's been a very much an increase in the wages and the salaries involved in that. And by far, our largest expense is salaries. About 25 to 35% of it used to be about 25, now it's closer to 35, sometimes 40% of our expenses are wages. And they're going up. And so those are a big driver. We're also subjected to the inflation and supply demands and as such. And, I have seen bills coming from supply companies where they have a fuel surcharge added. I never saw that before, but that's added to the bill. So I'm not making excuses, but because those are reasons. And I do like to say that, I do have a tremendous amount of confidence in the process of how Ontario and other provinces develop their fee guide. It's not just a bunch of dentists sitting around thinking, what do we charge? Believe it or not, it's an extremely objective process that adheres to a formula with multiple different inputs. And, that formula is right at the beginning of our fee guide, and the insurance industry has access to purchase a copy of that. So I don't want to go into that in detail, but it's a very strict process. And being part of that committee at one time, I do know we never got a chance. The dentists don't get a chance to see the fee guide until it's produced. They understand the parameters that go into its production, and they help influence those through surveys and their costs of their practice. That is done every year. They influence that, but they don't see the result until it's actually produced. So the little bit of an eye opener at 8.5%, I got to admit, there's a few dentists that open their eyes, but is it justified? In my opinion, absolutely. There are some different factors. All provinces, it's gone up to different degrees because there are some unique situations in different provinces. Some of the demographics are somewhat unique. You think of a practice in PEI or Saskatchewan, that's a lot different than Ontario or British Columbia. The geographics are different and the regulatory body issues are different. So there are some good reasons for some differences in the fee guide. But as a general, I think the process that the provinces use to develop their fee guide is very credible. It's very accountable. And I do believe it's well respected.
Can I ask, and maybe this is too inside and you can't answer, but do the provinces in advance of sharing the fee guide, do they talk amongst each other and go, we're at 8.5 Quebec, where are you? 9.8 Alberta, where are you? 6? Okay. We're all facing, no, it's all totally independent. Yeah. So if you get everybody kind of around the same numbers, you're getting showing that the process works across the country. Different groups are doing different things. Yep. With all sorts of different factors, but at the end, we're all seeing, this year much higher increases.
Yeah, you're absolutely right, and David, you're absolutely right. That does, in my opinion, it shows the process works. And the other thing that shows the process worked is, when I started practicing over 30 years ago, the formula was very simple, and it was very arbitrary how it was decided how the increase would be. And hence the utilization of the fee guide was less. I myself, speaking as an individual dentist, I used to say, I'm charging more than the fee guide for that. I'm charging more than the fee guide for that. I'm not going to charge the fee guide for that. I used to, I really did used to be very No, it is, and it is just a guide. Remember, it is just a guide. But now, over the past 10 to 12 years, I've found myself, I still do it to a certain extent, depending on the individual situation, because that's what I should do. But I find it much more reflective of what the actual costs are in average. In average. Now, we all know how many of us are that average person. So we do, that's why it is just a guide. But, full disclosure, and I may say something out of turn here, but I don't care. Dentistry is costly. But I do think there is value for that. When I think of, and I've had this discussion with medical folks, when you pay that fee to have a root canal done, and it's over $1,000, out of that fee, everything comes. The doc has to pay the rent, the hydro, the supplies, the staff, everything. It's not like medicine where a surgeon only gets such and such. Well, yeah, but that's what the surgeon gets. The cost of delivering that medical service, like the cost of going to the emergency room, is over $500. So dentistry is I won't use the word expensive. There's value. It's costly. But I always like to say it's a highly specialized healthcare service tailored to an individual by highly trained professionals using nothing but the highest quality materials in the safest of environments, zero wait time, and by the provider of your choice.
And you haven't even
which one of those do you want me to give up to make it cheaper?
None of them. And you haven't even talked about the cost of education to get in, the cost to establish or buy a practice. Those are huge multi-million-dollar costs now. It's not like you walk out tomorrow, hang up a shingle, and you'll be fine. No, you got $1 million worth of equipment your first day.
Yeah. So I don't wish, and I know sometimes I don't wish to sound indignant, but there is a tremendous responsibility to live up to that expectation, and that's where I'll throw it back on myself. Like, I can justify the fees I charge, but there's a tremendous amount of responsibility that I truly believe the vast majority of our profession embraces. There's a tremendous amount of responsibility to live up to those expectations. This is an insurance webinar, so hopefully you'll ask me a couple of questions about fraud later on.
You just walked right into it right here, right now. Okay. And I'm just going, I would say majority of people in any industry are good, rule following, meet or exceed the standards of the industry, but there's always bad apples. And to be fair, it's not all fraud. There's a bit of misuse and abuse and things like that along the way that maybe are in the fringes of, is it necessary? Is it unnecessary? That's a whole other professional discussion. Yeah. But we do see a fair amount of fraud. And I was hoping to do a survey of my neighborhood of dentists, asking, for example, who would forgive the fee guide. I did this last about 15 years ago, and it was around 40% said they would, forgive the co-insurance. I said the wrong thing. Yeah. And about 40% over the phone to somebody just calling saying, I'd like to be a new patient. Will you forgive the co-insurance? About 40% said yes. And that blew my mind. Now, to be fair, it might've been the receptionist, or it might've been somebody it was obviously not the dentist in most cases. But that's a big problem. And that is fraud. Take it where you want to take it.
Yeah, no. First of all, I don't have. It's going to be very difficult to find out just to what degree that occurs. But it's fraud. People sort of think, well, is this? Why are we doing this? Fraud is a victimless crime. No, it's not. No, it's not. It's fraud, and I'll fully admit to that. This is an issue. To me, the two biggest issues that our profession has to deal with are the acceptance or going after the copay, and also treating the insurance plan, not the patient. You need to treat the patient, not the plan. But both of our industries are guilty of that. Both of our industries
100%.
are guilty of that. But the copay is it is a problem. It's not a gray area. And
No,
the
that's not.
Ontario Dental Association, again, we're not the one that enforces the rules, but we have a patient fact sheet that we give to our members to give to the patients, because this is very much a demand from the patients as well. And the patients they'll vote with their feet. If you don't do it, they'll go elsewhere. So there's that fear of losing patients.
I know. I was just going to say, a few years ago, we had Dr. Roland Matsui, who's both a dentist and a lawyer, and unfortunately, he passed away about 7 or 8 years ago. But he spoke, and both his kids are dentists, and they were going up into Yukon and Indigenous communities to work. And he said, when they come back and work in the cities or wherever they choose to end up, he said their biggest problem is people bending and breaking the rules. And it just makes it that much harder. As you said, people walk with their feet when, you don't do what they want. They go down the street if they find somebody else willing to bend the rules, or in this case, commit fraud. And he said, that's a big problem. And the college talks about it. There's courses on fraud now. And, the associations are on it. There's all this stuff out there, but it seems to persist.
Because it's a difficult problem to police.
It is. Yeah.
And one of the main reasons why it's a difficult problem to police is because the college primarily, not solely, but primarily reacts and responds to patient complaints. What patient is going to complain that their dentist didn't charge them the copay? You're on mute, Dave.
Sorry, just like our industry, my turn.
Yeah. And I don't mean to sound flippant there, but it's a reality.
So I'm going to just jump in for a second here with some background for folks who may not be familiar with what this really is, because I think you're both very inside baseball on this. Yeah. So the concern here is, let's say, just for the sake of argument, I'm going to my dentist and the normal cost of something would be $500 and I've got a 20% copay. That's fair. So the dentist says, and I go to the dentist and I say, well, how about this? You waive the copay portion and you just charge me $400, but the whole $400 goes to my insurer, which, Dave, really means my employer, right?
Yes.
Yeah. So that's sort of what should happen. If the dentist only charges $400, then it should be $320 goes to the plan and $80 comes to me. That's fair.
No, and that's not just a good way of explaining it. That is the way to explain it, and it's a factor. There's lots of different solutions to that to enforce it, but it's difficult to enforce. It's difficult to police. And one of the things as well, I always like to say, and I'm not defending those that are guilty of it, that just because the patient didn't pay for it doesn't mean they weren't asked to. It's a pain in the neck to be a collection agent, like a service. It's a real pain in the neck. But some of the other solutions for it, just say no. You can do that. Don't take assignment of benefits. Assignment of benefits is a contributor to that. But these are all things that we've come into a marketplace right now where, again, the patient expectation is to be able to, no, you will take assignment. No, you will forgive the copay. It's easy for me to stand on a high horse living in a small town where the other practices in town don't take it, don't take assignment. It's easier for me to talk from my high horse. But if I was working in a major center, I understand it, but it's still wrong.
Yeah, and I'm going to help lift you up onto the high horse. I've got friends in dentistry in different communities. And one I'm thinking of right now, and they've just actually sold their practice, is in a lower income area. And they don't have patients unless they do assignment of benefits. And they do a bit of forgiving the co-insurance or not being aggressive accounts receivable chasers because of the financial considerations and demands from the patients. Yeah. And I took them to task at it once because they said, why don't you switch over to us as your dentist? Because mine was retiring. And I'm like, I don't want to be involved. I'm not about to report them because it's so flagrant. But But at the same time, I'm like, I can't be the person, especially in my role in the industry, as being the one who's committing dental fraud. Like, and I wouldn't let you do it and potentially risk your license. But they feel that because of that pressure from the patient, they don't have a choice. That's the only way they're going to get to be able to treat people. And
yeah, and it's a very interesting thing, because you made a comment there, whether it be not collecting the copay, or whether it be backdating an insurance claim, or whatever. Like, you're asking me to commit fraud. I could lose my registry. I could lose my license.
yeah,
So, is it kindness or ignorance? It's not ignorance. It's not ignorance. I
no,
truly believe it's not ignorance. Is it kindness? Well, I like to think of myself as being a pretty kind person, and I will give dentistry away to people that need it and can't afford it. But I'm not prepared to put my livelihood at risk. I'm just not prepared to do that.
yeah. And we all get faced with that in
Again, I
yeah.
can sound high horse and indignant, but it's fraud. It's professional misconduct.
Yeah, I'm 100% with you. And I mean, we face the same thing. I mean, we have employers that come to us and say, we want to make this fake group for the sole purposes of getting claims paid and things. And you go, what you're asking me to do is risk my license. Nah, it's not really fraud. I mean, it's the insurance company that's paying. No, the insurance company only pays for the benefits for their employees. Beyond that, role as an employer, they're not paying anything. The employer is, or whoever, the association.
Yeah.
Cool.
Can I just ask a follow-on fraud question here? I think we want to get to the national dental benefit thing, Dave, here, right? But so the copay issue, I think that's kind of that thing that we know is fraud. You've made a good case for this, David, right? But I think there's other examples that would be more, more obvious, more flagrant. Am I fair there? Do you think?
Yeah.
Go ahead.
Yeah. And I don't know how prevalent there are. Some of the other things, and I mentioned earlier, like treat the patient, not the insurance plan. And this is where I'd like to say I'm an expert at fraud, but I want to make it perfectly clear. I'm not an expert at fraud.
Yeah.
But okay. I had one dentist talk to me one time. Well, it doesn't cover sealants for patients over 12, so I just code it as a single surface resin restoration. And this is where I say you're treating the plan, not the patient. You're looking for what codes are available for the patient through their insurance coverage and using those codes. That's misusing the guide entirely. A lot of work. The Canadian Dental Association is the steward of the codes. The Ontario Dental Association does a lot of work at producing a very credible, highly respectable fee guide, and you have to use it properly. So it's not a tool of which to use as convenience in that way. So those are examples of fraud. And they're very specific examples. Having said that, dentists would say that the insurance companies they treat the plan, not the patient, because this individual patient needs a fluoride every 2 months, needs oral hygiene instruction, but their plan won't cover it, and it's simple. So this is where we can both do better on treating the patient, not the plan. This is where we can both do better. But Jason, that fraud does exist. Again, a lot of that can come from removing assigned benefits. There's something about giving that patient the bill and have them looking at it and, 3 fillings were done today.
Yeah.
And I remember him doing those 3 fillings. She did this today. And I remember, doctor, I remember when she did this for me today, as opposed to, I had a filling done at the office today, but the dentist coded that I had 3 fillings done. That's, I like to think that that's not prevalent, but we have to acknowledge that it does exist.
Yeah, we used to have and I'm not sure if they still do, 1 or 2 hospitals in Toronto that would give you a bill when you left, showing kind of an estimate of all the costs, and then, say paid by OHIP, your balance 0, and things. And the whole idea was to help people understand the true cost, not, you can just go to the ER for a sniffle, but no, there's a cost to all this stuff.
Yeah.
I had a question. I've just lost it.
That's okay. We can come back to it.
think about your fraud question, but I think we have to get in now to national dental coverage this is the ripped from today's headlines, as it were. And
Yeah.
yeah, Dave, I'm sure the question will come to you. So go, David, what's going on with national dental benefits?
Well, yeah, right now we already have in place three different federal programs that cover dental. There's the non-insured health benefits, which is primarily for Indigenous populations. There is the interim federal health benefits for refugees, and there's Veterans Affairs. So those three programs are federally administered and run. But most of the healthcare that we've always associated, most of the dental programs, we've always thought of them as a provincial responsibility. So right now, we have in place the promise of a federal Canada Dental Care Plan, but in the meantime, we have a Canadian dental benefit. It's and that's a federally administered. I'm not even going to call it a program. I'm going to call it a stopgap measure. Okay. Yeah. I will have a lot of good things to say about it. It's an interim step. But there's a lot of questions that can relate to that program. Right now, the basics are it's up to $650, so it is actually indexed depending on the average, the income, the overall income of your family. So if you are less than $70,000, if your family makes less than $70,000 a year, you get $650 per child for about 2 years. Okay, this is going to be in place for about 2 years. And child under 12, as long as you do not have any other private medical or dental insurance. If you have that, you don't qualify. If it's between 70 and 80, you get $390. If it's between 80 and 90, you get $260 per child. So it is indexed. It's administered by CRA, so you have to get this. The good thing about this program, I'm going to start off with the good thing. It is money directly to dental care. Directly to dental care. Does it target a population that needs it? Yes, it does. And when I say directly to dental care, it doesn't have to be used for a dental appointment. You can use it to go get a filling. You can use it to buy toothbrushes and toothpaste. So it's this. So overall, am I glad it's as a practicing dentist, am I glad it's there? Yes, I am. As a member of the Ontario Dental Association, am I glad it's federally administered? Yes, I am. And Jason, I think this is an important question because different provinces feel differently about this. Ontario, our provincial programs, and there's 5 of them, I think, and then there's different municipal programs, but our provincial programs are woefully underfunded and underutilized with poor access to them. So are they good enough? No, they're not good enough. They need to be much better. Whereas the federal programs tend to be better funded, better administered, better services. So that's why we're glad this is a federal program. Okay, get some
let me ask one question. Do you think the amount is a reasonable amount? And the reason I ask was I think the average spend for a Canadian on dental care is like $450 or something like that. Those are old numbers that we kind of inflated.
No, that's if you look at it, do I think the amount is a reasonable amount for the average person? And the answer to that is yes. And I'll tell you why in a second. I have patients that are going to need a lot more than that.
Of course.
I have patients that won't need that much. So this is the proverbial average. So we'll take $650. Because you're right, the national average, I think it's probably about 480 right now. Last year, I think there was about 16, and you just do the math. We'll do the math quickly.
Yeah.
I won't, and I promise I won't do it in my head. I actually did it here because you if you do the math and you've got the dental industry, there was about $16 billion spent in Canada last year. 33 million people, that works out to be about $480 per person. That's if everybody went. But not everybody goes. So when you look at the number, okay, say in Canada, about 74% go to the dentist every year. So when you look at $16 billion spread out at 74% of the population, believe it or not, that number is $667.
Oh, wow. That's fantastic. I'm glad you did that math.
Yeah. I don't know if that's how they did it. I don't know if that's how they did it.
Yeah.
But
well,
that's the number.
That makes total sense. And I was one of those people that never went to dentist for 12 years. So I get it.
Yeah. So to answer your question directly, is that a good number? Yeah, the number. Yeah, I can see where it's a reasonable number. But as a dentist, as a provider, again, we never work. I can count on one hand the number of people that I've ever treated that are the average persons. So there's that frustration level that will come in. But it is a stopgap measure. I will also go out on a limb here and say it was a political survival measure that they did that. But having said that, I will compliment them. Okay, if they're going to take the time to get a good program in place, then take the time to get a good program in place. And I think they're looking at about 2 years. So this still has the potential to be something really good because there, Dave and Jason, there's about 30% of our population that really need this care. And they don't have good access to it. And they don't have good utilization of the programs that are in place. And I know that that's very different from province to province. So on that point, I'm speaking very much in Ontario. But, just as a case in point, there's some New Brunswick just negotiated a new terms of service for their publicly administered dental programs for children. And their reimbursement level is 90% of their current fee guide.
That's not bad.
So they have no complaints.
Yeah.
Ontario
50%.
No, we're at 36%.
Oh, it's worse.
36%.
Which makes it hard for a self-employed entrepreneurial dentist to get somebody into the office knowing they're going to be paid just more than a third than the next patient.
So what it does is it limits your access. Because I'm a big believer in the best thing to hold dentists accountable is that if my patients aren't happy with me, they can go elsewhere. I'm a big believer in that. I think that's healthy. So take my wife and I, for instance, who say for the last 10, 15 years of our practice, we could afford to do just what we were doing because we had paid off most of our practice. This is just, I can afford to do that. But the young individual who she or he who just purchased a practice and is massive debt, it's better for them to have an empty chair.
Yeah.
Than see that. So and Jason, I'm very much speaking Ontario specific. The average spend on public dentistry in Ontario is $4.99. I think this is a figure of about 2 years ago, whereas the national average is about $21. And that's per capita. And again, that's not very much, but you're factoring that number out towards everybody as if everybody came. Yeah. Nonetheless, it's just Ontario is woefully low.
So I have some questions about communications around this program. We're seeing the fallout now from CERB and Qs where there was a lot of self-reported, like I don't have income or I do have income or I had this kind of income, and people qualified for CERB, and now we've got, I can't remember what the dollar amount is, but billions and billions of dollars of both benefits being, people always say clawed back, but reclaimed, whatever. And now we're going down the same path again of self-reporting. I don't have benefits, therefore I'm putting in an application for this $650 or less dollars. Do you think, do dentists have any sort of, I don't want to say obligation because that's not the word I want to use here, but is there, as the dentist, David, are you talking to your your patients and saying, you should be applying for this or you should not be applying for this?
Yes. The overall benefit, because you're right, the program's just in place right now. There's going to be abuse. There's going to be mismanagement of funds, and there's always a certain element of that that's factored in. I think the key here that they can use this is if they still continue, if the targeting is appropriate. In other words, it's targeted to the appropriate eligible families. That then you're dealing with a good starting point. You're dealing with a good starting point. They have the ability, when you look at the CRA website, they do have the ability to ask for receipts. As to what degree are they going to do that? I certainly, speaking as a general practitioner dentist, there's no way I want to be a policeman in that. There's no way. To me, this should be the dentist's involvement in this. What I like about this, our role is to provide treatment. That's our role. The patient has to pay for it. The patient has to pay us for it. So to me, and that's one of the benefits, is that this money is supposed to be funded directly at the care. The dentist does not have an administrative burden in this role. So where can they hold the system accountable? They can only do it through specific audits every once in a while, but they can go from a very good starting point by maintaining and be very stringent on their eligibility criteria. And okay, we're only giving this money to a family that is in this income level to start with. Yeah, whereas CERB, the other benefits, everybody was eligible for it.
And it's administratively difficult. So if your family qualifies based on income and partway through the year you get a benefit plan, where does that fit? And all of a sudden, after 3 months, you're let go. You don't have a benefit plan. Are you eligible? Are you not eligible? There's so many real life things that mess it all up.
You can apply for eligibility, and the other thing is you have to reapply for it. So the program now, it started December 1st, but it was retroactive till October 1st, 2022. And the first year goes till June 30th of 2023. Then they have to reapply. They reapply. We're only talking about for children here. Yeah. They were hoping at the end of 2023 they would have it for up to 18, and then seniors, who knows? And then they're not going to have a full program in place for everybody till 2025. So yeah, it's not perfect. It's not perfect, but it's a start. I will, as a GP, particularly working in a small town, and I live in the small town. I live in this town, and we have for a long time. So that's why I say there's a need for it. There's a need for publicly funded dental care programs, what used to be called Mother's Allowance. Do I know of evidence of where these programs are going to be abused? Yeah, I do. But overall, I'm really grateful that they exist. And I'm really glad that this is money directed directly to dental care. They haven't formed a whole other bureaucracy to deal with this. They're not saying this, we got $50 million for a program, which is what happened with Healthy Smiles when it first came out in Ontario. Here's $50 million for a program. And they built a bunch of clinics and never manned them. And a lot of money was spent. And this is what's happening with the seniors program in Ontario as well. A lot of money is being spent, but not directly on dental care.
Are you going to keep stats on this, or is there any sort of requirement, or because if the program works, you're going to have people in your chair who wouldn't have been in the chair otherwise. I think that's the win, right?
That's the goal. That's the goal. Yeah.
So who's going to know that that's happening, or how's that going to get back to policymakers? Or do you have a sense for that, David?
Yeah, and I don't know the exact. Am I as a GP going to take stats? They're going to be I certainly haven't been asked to yet, and it's a difficult thing to make that stat. I don't know how they're going to measure outcomes. And really any program deserves to have measurable outcomes. That's how you want it accountable. Right now, the only measurable outcome I think that they have in their toolbox is utilization of it. And I believe when I looked at it last week, about 100,000, they were estimating about 500,000 people may be eligible for it, and I think they've had about 100,000 already take it up. So, Jason, that's a very good question. And I don't know. It's a very good question. It's a very responsible expectation, but I don't know with this benefit versus program, that's a realistic expectation.
Yeah, and you would hope
they have it must be a realistic expectation when they actually come out with a program with proper measurables. But again, I'm going to go back, and this was political survival.
Yeah, and you would hope that they would take good feedback to build the program and not go down the Healthy Smiles route or some of the other ones that we've had in the past.
Yeah, and just for your other listeners, Healthy Smiles is the children's program in Ontario,
which is like public school screening when you're young. And for lower income families, there's coverage. Basically. Yeah.
Yeah, exactly.
Jason, can I kind of
hand it to you for our very last question here? Yeah, if you could.
I've kind of got two. So the first one is, I've been in the business for just over 26 years, and in the employee benefit space, and we have not seen very much change in plan designs that employers offer. So, 80% co-insurance basic coverage to maybe $1,000 or $1,500. Maybe you're a little bit bigger employer, you might get some major in at 50%. And if, God forbid, you have a fantastic employer or a larger company, you might have orthodontics. But that has not changed in 26 years. What do you think, as both an employer, which you are and have been, and as a dentist, what should we be doing and looking at changing? Obviously, keeping in mind the employer's paying the tab at the end of the day.
Yeah, I'm going to start off by saying, this is my opinion, but I'm firmly believe that there will be significant scientific evidence to back this up. I just don't have it at my fingertips. But healthier people are cheaper people. They don't cost as much. So I think you really want to have a plan that encourages people for that to get healthy. And in the dental world, does that mean that the annual limits or annual maximums need to increase? Yeah, they do. The dental world has changed. The cost of services has changed, but there's a certain element that's also changed. We've always tended to focus, dentistry has a history of tending to focus on prevention. And I do think that plans in the future need to take into consideration a lot more preventive aspects, a lot more of the periodontal maintenance. And this is I'm going to give the same evidence or the same rationale to employers and insurance companies that I would give that the Ontario Dental Association has been giving to the federal government on this, is that you want to develop a program that makes it really easy for people to get access to care for the basics of care and like fully fund the basics and asset or access to that. So preventive care, periodontal care, yes, restorative, like just knock that one right out of the park. For some of the major ones, I get that completely. Like, no, they're not covered to the full 90% or 100%. They're cut back. I get that. I think you have to maintain that, and that's reasonable. But you do want to look at some of the changing perspectives of that. And this is some of the changing standards of care. When I graduated, implants were pretty experimental. Now, if I had a single tooth with two really good teeth on either side, give me an implant. Don't give me a bridge. Give me an implant. It may be a little bit more, but it's less expensive in the long run.
Yeah.
A 4-surface or a 5-surface resin filling on a molar right now is $500, Dave.
Yeah.
Put a crown on it.
Yeah.
So I think this will get me back to treat the patient, not the plan. This is where I think insurance companies can do better, whether they incorporate a certain flexibility into the benefits. And I know there's been toying with that in certain things, because you can say you have $1,500 a year maximum. Well, a lot of patients don't need that, but some patients need 4,000 or 5,000. So is there a way to try and individualize it? Because when we're talking dental insurance, correct me if I'm wrong, Dave and Jason, but we're not talking insurance. We're talking prepaid dental benefits.
Exactly. 100% right on. And that's the part that everybody fails to realize.
I get it. You have to realize that's what it is. And because, make no mistake, and I've had patients that are saying, well, should I continue with my insurance benefits or should I wait for the National Dental Care Plan? No. Canada enjoys one of the highest standards of oral health in the world. And I'd like to say that's all because I'm such a good dentist. But it's only half true. No, it's only partially true. Like, third-party insurance and the private insurance industry, as a practicing dentist, I would like to thank you. And employers, I would like to thank you because you have facilitated that. That is one of the main reasons why we have a country that has overall good access to care, overall good utilization of care, and good services. And I want to thank you for that. And I'm not just trying to be sentimental here because I'm talking to a bunch of insurance folks. It's true. Keep it. Your employer-based insurance benefits are very valuable, they're very appreciative, and they're very attractive. Keep them. It works.
And that's a great place to end, other than I'm going to say, you guys have done a great job of preventative care. I mean, my dentist calls me for my and puts forward dates for reminders for my checkups, cleanings, or whatever. My family doctor doesn't do that. I don't have, there's nothing preventative in the non-dental medical profession. You guys lead the pack that way. Now, some might say, well, obviously it's self-serving. There's self-employed entrepreneurs. They want you to come back in. Yeah, but there's positives to all that. So I would like to say thank you to you and the dentists that are consummate professionals helping people every day. We couldn't do it without you, and us not having a good dental process, and even the fee guide, whether we like it or love it or hate it some days, it means our business stays healthy as well. Yeah. So Healthy Smiles, sorry, not the program, but just overall benefits everybody. So super.
No,
thank you.
And you talk about self-serving, Dave. I'd much rather, during the week before Christmas, I'd much rather go in and see everybody who's coming in for their regular recares or to fix the filling here, and wish them a happy Merry Christmas and a Happy New Year. I'd much rather be doing that than seeing them on a dental emergency over the holidays because they couldn't get access to care. And I have done that. Done that. And it's a lot more fun to see people more often for the basics, healthy care.
Fantastic. Jason?
It's a great note to end on. Thanks very much, David. Really, really a pleasure to get to meet you. And I feel like this is such a great compliment to our last episode, Dave. Our last episode, David, we talked to a small town pharmacist.
Okay, good.
Yeah. So just a great look at both sides. So really appreciate that, David. Your depth of knowledge is fantastic. I love when people know, and Dave knows I love this, when you pay attention to the regulatory side of your business as well, like when you understand that history and all that goes along with that. So thanks very much, David.
Oh, you're very welcome. It was a real pleasure. I liked it the first time Dave asked me to do something. Ask away anytime, Dave.
And thank you. We appreciate it massively. Every little bit of education helps our advisors and our listeners, and helps them help employers, which help the employees. It's all good trickle down. So thank you very much.
Good stuff.
Okay, I love these interviews. I hope Dave keeps bringing me these wonderful practitioners who understand their practice, but also understand regulation and can get us some insight. This was great. Pretty rare, honestly. I always look for dentists and other practitioners who do this kind of work. And not that common to find folks out there who know their business this well and know the regulatory side this well as well. So thanks very much for David Stevenson for coming on, and thanks to Dave Patriarche from Canadian Group Insurance Brokers. And you'll find a link to CGIB. Strongly encourage anybody out there who's active in the group benefits community to join CGIB. It's a wonderful, wonderful learning resource. I'm involved as we speak in a couple of conversations there about what exactly is permissible as far as membership in health spending accounts, and a curious little distinction between what the Income Tax Act says and what CRA says. So anyways, the number for today's episode is 8. The number is 8. And finally, I hope you'll join me again in 2 weeks' time. I have Chris Enns coming on. Some of you, if you listened to Sandy Martin's podcast when she had a podcast, you'll maybe know Chris. He is a creative who does financial planning for creatives, so artists and the like. And I really have always enjoyed the interactions I've had with Chris, so I'm looking forward to that one. Please do again join me in 2 weeks and enjoy your continued studies.
Hi, if you're listening to this episode and you're not already signed up for CE credits, this is a very easy thing to do. Just navigate over to businesscareercollege.com and you're going to sign up here for CE. Just subscribe. Currently, the pricing is $200 a year. We may be introducing monthly pricing at some point, but as of today, we have a cost of $200 a year. And once you're signed up, then you can just go and listen to every episode within your subscriptions. So you'll use once you're logged in, you'll use my subscriptions here, and you'll just go to the latest episode, which you'll scroll down to very near the bottom for. It doesn't matter which episode, you just scroll down and you find the one. So as of the time I'm recording this, the most recent episode is season 4, episode 27. I can just start it right from here. I can do the quiz here. Once I'm done the quiz, then I can get my continuing education certificate. Very straightforward. So I would just launch the course here, and I can watch the episode from here. Now, if you happen to be already listening to it on YouTube or whatever the case is, you can just navigate right into the quiz. You start your quiz, and you're just going to go through the whole thing. And then at the end of it, you'll be able to see your certifications. So we're going to bring up designing small group products. We bring this up and we click on wall certificate, and that's going to give me the CE certificate I need in order to maintain status wherever I happen to need CE credits. So I really do encourage, I know that out of our regular listeners, about 40% of you are listening to the episode for CE credits. That's about 60% who are listening out of general interest or whatever it is. And I really think this is an easy way to get your CE credits, $200 a year, pretty reasonable price. And as you can see from the certificate here, and as you hear me discuss at the beginning of the episode, we have a broad range of approvals for all of our courses. I'd like to thank Joe Tong. Joseph is our editor, both for video and audio content. And Joe does a lot of good work to make sure that these episodes look and sound good, despite my better efforts. I'd like to thank Maria Nguyen. Maria makes sure that the episodes all get approved for CE credits. Veronica Thibert does the quality assurance through that process. And then we have a strong marketing team that makes sure that all of our content gets out there so that people can find us and take advantage of learning opportunity they might not have known about.